Welcome, everyone, to the third edition of the National Virtual Leukemia Conference. This one-of-a-kind conference addresses the unique needs of the blood cancer community and offers the latest information, tools, and resources to help support Canadians touched by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation, Treatment Options for Chronic Myeloid Leukemia and How to Minimize Side Effects. In this session, Dr. Lynn Savoie, hematologist at Tom Baker Cancer Center, will discuss treatment options including hematopoiesis, stem cell transplants, and ways to minimize side effects of CML and its treatment. Before we begin, let me introduce myself. My name is Catherine Yerkew, and I am the Community Services Lead for the Prairies. I will be the moderator of this event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of the questions aloud at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all the questions. I also note Dr. Savoie cannot answer specific questions about a person's health history or status. Today's presentation will be recorded, therefore you can rewatch it again on our website. Slide 2, please. As we come together from across Canada, we recognize that we are on the lands cared for by many Indigenous nations. We honor the First Nations, Inuit, Métis peoples whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. Next slide, please. Are you looking for specific programs or resources but not sure where to find them? We're here to help. You can connect with the community services lead in your area to receive personalized assistance and get connected to resources in your area. Please reach out by calling 1-833-222-4884. Next slide, please. We know that having a diagnosis of CML can be very overwhelming, but know that you are not alone. There's a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-to-one support to help navigate the blood cancer experience. Next slide, please. We invite you to visit our website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Next slide, please. On our website, you will find tailored information and resources in multimedia formats to address the variety of needs and preferences, including those specific to CML. This includes recorded fact sheets and booklets like the one you see on the screen. Next slide, please. We have a podcast channel, The Blood Cancer Experience. You can find hundreds of podcasts for people touched by blood cancer, many addressing challenges for people living with CML. We speak to experts about current topics such as treatments, diagnosis, and research. We will also hear stories from people touched by blood cancer. Next slide, please. And finally, some information and resources to watch, like the series of an animated video on CML, understanding treatment options, side effects, and genes. Visit bloodcancers.ca to read, listen, and watch all of these great resources. Next slide, please. We launched in October the LLC's Travel to Treatment Study. The study is to measure and quantify how traveling to cancer treatment affects individuals and families. We want to gather and present information to decision makers to help them understand the real-life impacts of traveling for treatment to improve support for individuals affected by blood cancer. The study will examine factors contributing to individual experiences, finances, education, housing, and employment to see how travel affects these life factors. Please fill in the survey using the QR code. You will also receive a direct link to the survey in a follow-up email 24 hours after this session. Thank you for taking a few minutes to fill in this important survey. Next slide, please. It is now time to introduce today's speaker, Dr. Lynn Savoie. Dr. Savoie is a clinical associate professor in the Departments of Medicine and Oncology at the University of Calgary, as well as a member of a Department of Hematologic Malignancies and Bone Marrow Transplantation at the Tom Baker Cancer Centre in Calgary. She received her medical degree from Dalhousie University in Halifax, where she also completed her internal medicine residency. Her hematology fellowship was completed at the University of Manitoba, followed by a clinical leukemia bone marrow transplantation fellowship with the Leukemia BMT program of BC. Her interests lie in myeloid malignancies and medical education. She is a local primary investigator for a number of clinical trials, including CML, AML, MDS, and ALL. She is the current secretary of the recently formed Canadian Leukemia Study Group and the co-chair of the Leukemia Subcommittee at the Canadian Cancer Trials Group. She's the previous chair of the hematology component of medical education at the University of Calgary, as well as the chair of the hematology exam committee at the Royal College of Physicians and Surgeons. Thank you for being here today. Over to you, Dr. Savoie.
Hello, everybody. I'm going to try to very quickly, in about 50 minutes or 45 minutes, do an overview of CML. It's a very high level. We're trying to hit on a little bit of everything, but you can see sort of where we're going from this slide. So you probably all know this, that in our blood there are many components, things we can measure, electrolytes, test for for how the kidneys are working or how the liver is working. But there are only 3 types of blood cells: the white cells that fight infection, the red cells that carry oxygen, and the platelets that help the blood to clot. Our lymphatic system consists of the bone marrow, which is the spongy center of the bone. If you think of a soup bone, the squishy stuff in the middle. Lymph nodes, which are found everywhere throughout the body, as you can see in this slide, that help trap and kill diseases and infections and are filled with lymphocytes. And the spleen, which is over on your left side, that helps filter the blood. So leukemia in Greek, we use a lot of Greek words in medicine. Leukemia actually means white blood. So there are many different kinds of leukemia, and what they all have in common is typically an elevated white count of some sort, either in the blood, but for sure in the bone marrow. In 2024, there's almost 50,000 people who are living with or have had leukemia, and about 6,600 people will be diagnosed or will have been diagnosed this year. We're here talking about CML, which is actually one of the rarer ones compared to some CLL, for instance, which is another chronic leukemia, which is much more common. So CML typically begins in the bone marrow. A patient will have abnormalities in the bone marrow for a long time before it's detectable in the blood and it comes to light that a person has CML. Exactly how long is difficult to say because we don't generally leave a person untreated. Once we know, we treat. So difficult to say how long it's been in the bone marrow, but it usually has been for some time before it becomes evident. A person can get CML at any age, but most are adults. It does increase in frequency as age increases. There's a mutation in a normal blood stem cell, the cell from which all the red cells, the white cells, the platelets come from. There's a mutation in one cell, but then that cell divides into 2, then to 4, then to 8, and you end up with more CML cells than actual healthy cells. Because of that, and the fact that the bone marrow is stuck inside the hard bone and cannot grow forever, it's limited in its growth. If there's multiple CML cells that are dividing, there is less room for other cells, such as the red cells, which typically then start to drop. CML is slightly more common in males than females, and as I mentioned, the risk of getting it increases with age. In a few instances, there is the possibility of a previous radiation exposure, but this is usually in very high doses, like nuclear accidents, for instance. Um, Also, sometimes from radiation that has been given in the past for another cancer. Now, this mutation that happens in the cell is caused by this BCR-ABL fusion gene. What happens is a piece of chromosome 9 and a piece of chromosome 22 switch. So a piece of chromosome 22 goes off and detaches and then goes on to chromosome 9 and vice versa. The new abnormal chromosome 22 is known as the Philadelphia chromosome. It was discovered by a researcher in Philadelphia. And so here's a pictorial of that. This is sort of the normal healthy state. And you can see this little bit of red from chromosome 9 is now over here on 22, and a little bit of gray from 22 is over on 9. And this guy, this is the Philadelphia chromosome. This is the cause of the problem. This the gray and the red coming together brings two genes together that should not be together and turns on the white making cell apparatus such that you again continue making more and more and more white cells, but all with this mutation in them. So more of them make more, and it's a vicious cycle. This is a picture of real life uh, Philadelphia chromosome under the microscope. So these are all our chromosomes, and they line up chromosomes 1 and 1, 2 and 2, 3 and 3, etc. That's how they test them. That's how they line them up. And this you can see that this chromosome 9 is slightly longer, and this chromosome 22 is slightly smaller. This is our Philadelphia chromosome. What does a person experience when they have CML? Well, it's relatively slow growing, so some people have no signs or symptoms and are actually diagnosed when they have blood work for some other reason, a complete blood count or CBC done for preoperatively or for their annual physical or such something. But those who do have symptoms, again, typically would have a higher white count, can have problems with weakness and fatigue, shortness of breath, and those are typically related to that dropping red cell count or what we call anemia. They can also have fevers, bone pain from this marrow trying to grow inside the bone, and unexplained weight loss. Cancer cells use up a lot of energy, so people have eat normally but still lose weight. There can also be pain in that left upper side of the abdomen, just under the ribs, or feeling of fullness from an enlarged spleen. It can also make people eat less, be able to eat less, which can lead to the weight loss, and can have night sweat, so feeling very warm and damp to the point of needing to change the bedclothes or pajamas. So, how it's diagnosed, again, typically a CBC or complete blood count, accompanied by what we call a peripheral blood smear, which is when the laboratory technicians actually put a drop of blood on a slide and look at them under the microscope and see the cells, actually see them, not just put them through a filtering machine that counts them. We then do a bone marrow aspirate biopsy, and probably most of you guys have had one of those. So again, we're taking a little sample of the liquid and the solid stuff in the bone marrow to look down the microscope and send for a number of fancy tests, including cytogenetic analysis, which is that picture I showed with all the chromosomes lined up, FISH, which is another way to look for the chromosome 22, and qPCR, or polymerase chain reaction, where we can actually look for the mutant DNA that is produced by that new chromosome 22. There are typically 3 phases of CML, what we call chronic phase, which is where most patients are diagnosed, where there's again mild or no symptoms, but the white cell count is high. And these patients usually do very well with treatment, respond well, and live long, healthy lives. In accelerated phase or blast crisis, there are more of these blasts which are the baby white cells. So they're sort of the first cells after your stem cell. You go to a blast cell, and then you gradually differentiate your white cells into the normal cells we would normally see in the blood. So in accelerated phase, you see 10 to 19% of those blast cells. Healthy, normal people usually have about 2%. These basophils, which are mature white cells, are also increased. They can be increased in chronic phase, but just a little. But if they're up to 20% of all the white cells in the blood, that's part of accelerated phase. There can also be more chromosomal abnormalities. So beyond the 922, when they do that test where they line up all the chromosomes, they can see other bits that are missing or have flipped, and the symptoms that we talked about are usually more pronounced. In blast crisis, you have more than 20% of those cells, of these blast cells. You can have deposits of cells in other areas of the body. That's what this myeloid sarcoma is. Blast crisis can actually be lymphoid or myeloid. So different kind of white cells can be the ones that blast off. And the symptoms become more and more and more. And the blast phase of CML looks and behaves like AML or ALL, like an acute leukemia, meaning it progresses quickly and needs quite significant therapy. But most patients, and I'm hoping all of you, are diagnosed in the chronic phase, and with our treatments, don't progress to the other phases. People can start out in them. If they haven't had blood counts for a long time, they can show up in accelerated phase or blast phase. Most people start in chronic, and we manage to keep them there. What might make a person do well or not do well? What is their prognosis? What's their likely outcome? There's a few things that make it harder to treat CML that suggests that a patient isn't going to respond to treatment quite as well. Those can include, again, accelerated or blast phase, like we just talked about, being older, having a very large spleen, and either very high or very low platelet counts. The higher the number of blasts in the blood, which kind of relates back to this accelerated or blast phase. But even if it's not up to 10, 9 is worse than 8 is worse than 7. An increased number of basophils, those that are more than 20%. If they're more than 20%, it's accelerated phase automatically. But again, if they're higher than normal, that also makes us worry. And there are various scoring systems that you can find online where you take basically these measurements and you can plug in the numbers, and they divide patients into categories of chronic phase CML, such as low risk, intermediate risk, high risk. There's one called the SOCAL score, there's one called the UTA score, there's one called the Hasford score. So as physicians, we do use those scores to help us decide how aggressive we may need to be with our CML, or to help tell our patients how well the treatments we're going to suggest are likely to work. So when we're looking at treatment, we need to make a treatment plan. Here's that risk score that we talk about. So we do the risk calculation. We have ideas just based on our history and experience that the higher these things, the higher the basophil count, the higher the blast cell, the higher the spleen. Intuitively, that that probably means the disease is worse, but these scores have been devised to try and put numbers on things. What phase is the patient? The risk scores are generated for chronic phase, but if someone's in accelerated phase or blast phase, that obviously plays into how we're going to treat them. Other test results can play into it, such as if there's other cytogenetic abnormalities, or other test results that say that their health isn't as good. And that's over here as well. A person's age and their overall health contributes to our treatment planning. So two people with the same, more or less, CML, chronic phase, same risk score, may be offered different treatments depending how old they are and what their overall status is in terms of their health, their kidneys, their liver, their heart, etc. We're lucky that we have a number of medications that we can use, and some are harder on some organs than others. So we do need to take into account a person's overall health status to decide which drugs we're going to use. So, what are our goals? Our goals in both instances are to try and get to a remission, which would be akin to a cure. We often don't call it a cure because it's a chronic condition. It is something that people will live with for the rest of their life in some capacity, perhaps in remission, which means that the disease looks all the world like it's gone and perhaps even off medications, but we continue to monitor people for the rest of their life in case it does come back. Going back to the fact that it can take a long time to grow. People with chronic phase who achieve a remission are actually expected to live a normal life expectancy. In accelerated phase and blast phase, again, we do want to try and get a remission or at least back into chronic phase, but our treatments need to be more aggressive. So, when someone first shows up with this high white count, sometimes even before we can do all the tests to see if it is CML, when we see a blood count, we often have a high suspicion this looks like CML, but we have to do those tests, the bone marrow test, send it for those cytogenetics, for that FISH, for that PCR. And these tests take a long time to come back, from days to a couple of weeks. In the meantime, we don't like to let people sit with a very high white count. So we have things we can do to to bring the white cell count down. The problem with having too high a white count, and we're talking very, very high in the hundreds, is that it can lead to things like headache and difficulties breathing and chest pains. We don't want that. So we have this medication called hydroxyurea, which is a very old, non-specific chemotherapy type pill that brings the white count down. It doesn't do anything to really fix the problem, in terms of the CML itself, but it will bring the white cell count down to avoid those symptoms I was just speaking of. If the white count is very, very high, and if a patient does have some of those very worrisome symptoms, we can actually filter the blood and filter off the white cells if necessary. That is quite rare, though. So, the mainstay of our treatment in this day and age for chronic phase are these, what we call for short, TKIs or tyrosine kinase inhibitors. They are targeted therapy and they are pills. And there are many targeted therapies now, but the first one was imatinib, and it was designed for CML back in the 1990s. Um, so these TKIs target the abnormal BCR-ABL protein. So you have a piece of chromosome 9 and a piece of chromosome 22 that flip. You get your chromosome 22 and you get abnormal DNA. That DNA goes to RNA, goes to protein. You have an abnormal protein that is what stimulates the ongoing production of white cells. If you block that protein with this drug or this category of drugs, those CML cells that have the abnormal protein will die off, and then the healthy cells will start to come back and take over. So we start with our therapy, which we typically call first line treatment, knowing that sometimes we'll go on to second line, third line, fourth line. In accelerated phase, we will often still start with the TKI if somebody shows up in accelerated phase, but usually at a higher dose than what we would normally use for chronic phase. If somebody starts in chronic phase and the medication they're using, for instance, doesn't work, whichever TKI we've chosen to start with, and they progress, then sometimes we'll increase the dose of the current TKI or prescribe a different one. They're all a little bit different. They work mostly the same, but some can work better for one person than the other. There's also this omacitaxine, which we don't use very often, but can be used in people whose disease hasn't responded to up to at least 2 TKIs. We sometimes still transplant people, do bone marrow transplant or stem cell transplants from blood for CML, although those are quite rare. In the 90s, CML was the most common reason to do a transplant. Now it's one of the most rare. And obviously, there can be clinical trials or looking at new medications or combination of medications or different ways of using medications that we already have. In blast phase, clinical trials are most helpful. Other than that, depending on the overall fitness of a person, they would usually get very strong chemotherapy and have a stem cell transplant. There are some of the TKIs that are more potent than others, and we typically reserve them for the blast phase, or I guess certainly use them in blast phase where we might not in the other phases. So, as mentioned, we actually have now 6 different TKIs, 5 standard TKIs, and a novel one that blocks a different part of the protein, that abnormal protein I was talking about. So, the first 5 all block the same amount, the same spot in the mutant protein. Um, all these TKIs, all these drugs have a lot of the similar side effects, but they all then have their own specific thing. The first one that came along was imatinib, known as Gleevec by its brand name, and we can use that pretty much for anybody. And what we're talking about here is the approvals in Canada of these medications. Some of the medications, not every medication is approved for every situation. Then along came dasatinib and nilotinib that we'll see on the next page. Again, we can typically use those in almost anybody. There's your nilotinib. Bosutinib then came along, and you can see it's not approved for use in children, for instance. Ponatinib is approved for a very specific type of CML where, believe it or not, you already have a mutant. You can get a mutant in your mutant. So this is a mutant in your already mutated cells that leads to CML. So this is a drug that is very good for that and very good for these more aggressive phases of CML. But it has more side effects. So, like anything you can think in medicine, the more aggressive therapies are going to have more side effects. So, we reserve this drug usually for more advanced diseases or these specific mutated mutants. In the last few years, there's been a new TKI. This is the one that blocks a different part of the protein than the other 5. It also works in this T315I. And you can see right now in Canada, we can only use it if you've had 2 or more other sort of standard TKIs. And then the omacitaxine that we talked about before, again, in people who are resistant or intolerant to at least 2 TKIs. Before we had TKIs, we had these other medications that may, in this day, still be used in select patients. This hydroxyurea that I mentioned that we will often use at the beginning if someone has a high white count before we know for sure it's CML. Or sometimes if we do know it's CML, but the white count is still very high, we'll use this to bring the white count down because those other TKI drugs take a little bit more time to get the white count down. Cytarabine is sort of the same idea. It's a non-discriminate blood-killing cell. These interferons were really the mainstay of treatment before we had these TKIs. but we don't use them much at all now. Sometimes people try and use them in combination, thinking two ways at coming that the problem might help, or in pregnant women, that is certainly a place where we will consider these medications. That is because women should not bear children while on a TKI because there have been reports of birth defects and enough to make us worry that it's because of the TKI drugs. And so if we need to use a TKI in a pregnant or a drug for CML in a pregnant patient, we'll usually use one of these. Men can father children while taking a TKI. There's absolutely no concerns there. Stem cell transplant. I'm a stem cell transplanter as well as treating CML who's not being transplanted, is the infusion of donor stem cells into a patient after very strong chemotherapy plus or minus radiation, and is an option for a very specific subset of CML patients. It is a very risky procedure with even life-threatening side effects, so and not a good option for older patients or patients with other significant health troubles. But it is an option. Again, who do we transplant depends on where their CML started, what phase, how have they responded to therapy, how old they are, and their general health. Now, side effects of our drugs. Common side effects of all the TKIs, you'll see on the slides as they come. A lot of them can affect the digestive tract, cause some amount of nausea or vomiting or diarrhea. They can cause cramps, bone pain, rashes, tiredness. And those you'll see are pretty common to most of the TKIs. But imatinib has this fluid retention problem. It's kind of its own thing. It can be what we call periorbital around the eyes, or sometimes in the lower legs. Most of them will also cause low blood counts. But if you retain enough fluid, it can lead to congestive heart failure. Imatinib can also be tricky for the liver. So if somebody has problems with their heart, sometimes we worry about using imatinib. Dasatinib, you can see here again, nausea, diarrhea, fatigue, rash, fever, low cell counts, common to all the drugs. Specific to dasatinib is fluid retention around the lungs. Or sometimes the heart, less commonly. This is different than the fluid around the eyes or in the lower legs that we see with imatinib. So we watch people, we ask them how they're doing. Do they have a new cough? How's their breathing? Check their oxygen with that clip on your finger. Sometimes do chest x-rays if people are having symptoms. And you can also get this pulmonary arterial hypertension, which is quite rare, where there's high blood pressure in the arteries of the lungs. If we have these problems, we manage them. Sometimes they mean we need to switch drugs to one of the others, or sometimes we just need to stop the medication for a while or reduce the dose, but you'll see all of these different things happening to people. Nilotinib, nausea, vomiting, diarrhea, rash, headache, fatigue. We've seen them in all the TKIs, muscle and joint pain. This one can cause some respiratory things, runny nose, sniffing, sneezing. Low blood counts like all the others. This one we worry about blood clots, liver damage, high blood sugars, and the pancreas getting upset. Fluid retention, really a little bit, but not so common with this one. But we worry about sugars, so high, leading to diabetes or worsening a patient's diabetes. So we have to watch for all those things. Bosutinib, again, can cause fluid retention. Its fluid retention profile is similar to dasatinib, the second one I mentioned. For instance, about 50% of people who had fluid around the lungs with dasatinib, if you try this one, 50% of them will have fluid retention again. It can cause kidney problems or liver problems, but it's actually quite well tolerated. The diarrhea, although we see it with all of them, can be more pronounced with this drug. And actually, when they first started using this drug, they used to start everybody on full dose straight away, which we do for all the other drugs. But this one, and that caused a lot of diarrhea in a lot of people. So with this one, we tend to start with a low dose and build it up, and then we can usually manage the diarrhea much better. Ponatinib, it's the most potent of these five. It has, again, a lot of these same things: fatigue, headache, low blood counts, but it can lead to high blood pressures, heart troubles like heart attacks, fluid retentions, bleeding. So we worry about this one. Remember, I said we tend to only use it in those patients who have, more accelerated phases of the disease or that mutant in their mutant, that T315I. Asciminib, this is the latest one, the one that is slightly different, that blocks a different protein than the other five. Of course, it can also have fatigue, nausea, rash, diarrhea, low blood counts. It can sometimes affect the pancreas, rarely these heart troubles, less so than ponatinib and probably less so than some of the others. Um, and um, it can also cause a bit of diarrhea. So these lists that you're seeing, they come out of the clinical trials. So when they've studied all these medications, they the patients that are on the medications are asked, are you having any of those things? And if anybody anywhere says yes, it gets counted. And this is why we have these common side effects that a lot of people had, and then these rare side effects that only a few people had. But they all have to come out, they all have to be looked at. And so um, there's little signals with different drugs. Maybe this is more of a thing, maybe that is more of a thing, but they all have some side effects, is the bottom line, and we do our best to help you guys navigate them. Omecitacine, I can honestly say I've never used it, but the list tells me these are the common side effects. All the others are oral. This is an injection. So again, it can have a lot of the other side effects that we know. So we do, as I said, want to make sure that patients tell us about their side effects. So please make sure to tell us about any new symptoms when you start the drug or anything that happens, even after you've been on the drug for a significant amount of time, because it may or may not be related. If we think it is related, we will try and help you. If we think are quite certain that it's not, we may refer you to someone else or refer you back to your family doctor to have that looked into. But many side effects can be managed with lifestyle changes and or medications. You'll hear a lot about weakened immune systems with people on chemotherapy. We don't feel that these drugs weaken the immune system very much. Initially, when you're first diagnosed and the majority of the cells are CML cells, there is some element of having a weakened immune system. But once we give you the medications and we bring your sort of blood making apparatus back to normal and to health, we don't usually see as much of a weakened immune system. And that was borne out in COVID times where patients with CML had COVID did just as well as regular patients. We do recommend, though, for everybody to get vaccines. Again, yearly flu shots, COVID boosters, your pneumococcal vaccine, your shingles vaccine, if you are in the age range for those. And of course, if we have a stem cell transplant, interestingly, you have to have all your vaccinations again, but your doctors would talk to you about that. Wrapping up soon here. How do we monitor treatment response? You may have probably heard about this PCR or qPCR for BCR-ABL. So that thankfully is a blood test that we can do every 3 months initially. And if you're super, super stable, sometimes we reduce it to every 6 months. There were these other tests, blood cell counts, your regular CBC, fish that we can do on blood and or bone, and sometimes we need to do bone marrow tests if there's something weird going on. So again, if we do a bone marrow, we can do this testing. At the beginning, we're doing it to look for this chromosome 22, but down the road, if the CML maybe stops responding to treatment, we might do another bone marrow and another karyotype like this and see if there's other mutations happening. This can only be done on bone marrow. And when we do, when we do this, we only look at about 20 cells. So most of the time a diagnosis, all 20 cells will have the Philadelphia chromosome. There's this FISH test where you can see, we can do this on blood or bone marrow. You can see a normal, I don't know which is which between green and red, but say green is 9 and red is 22. You see 2 healthy chromosomes 9, 2 healthy 22s. Here you see one of each, but then you see it's kind of yellow where the 9 and 22 bits have come together. And we can do this on 200 cells. So we can see out of 200 cells, how many cells are abnormal. So at the beginning, most of them are abnormal, but as we treat, we see fewer and fewer cells. We don't do a lot of FISH anymore because we can do the PCR. I don't have a picture of how you run the PCR test. It's quite complicated, which is why it can take several weeks to get the results. But what the PCR does is tell us how much abnormal DNA there is. So when we start out, there's about 10 to the 12 cells, so whatever that is, billion, trillion cells in our bone marrow and blood. And most of them at the beginning will have the abnormal BCR-able DNA. So 100% will. And then as we treat, we knock down how many cells still have the abnormal DNA. And this is math, but if you start at 100%, you go down to 10% of cells, that's 1 log, you've lost a 0. 2 logs, you've lost another 0, you're down to 1%. 3 logs, you're down at 0.1, or from 10 to the 12 to 10 to the 9. The tests that we do, these PCRs that we do, can measure down to about here, about a 5 log reduction. Between 4 and 5, depending on the lab. And so we can measure down to here, and then we're very excited. We're like, it's undetectable. Undetectable doesn't mean gone, right? You could still be down here and still have a few cells that have it. But undetectable is as good as it gets in terms of measurement, and that's what we hope for all our patients and try to aim for. So I wanted to show you those slides to explain the types of response we're looking at. From a blood perspective, the blood counts returning to normal. Cytogenetic perspective, there's some definitions here, but basically our goal is to get so that none of the cells have that abnormal 22. And then from a molecular response, again, getting down to that undetectable level down here, deep molecular response, that is the best. An MMR is still pretty good. An MMR means you might need to continue on the medication for the rest of your life, but you're going to be okay. I talked about this. You can have a mutant in your mutant. And that can either lead to the first drug not working or a drug works and suddenly it stops working because the mutation could have happened before we figured out you had CML or can happen while you're on treatment if there's still some CML cells left if you're in that narrow part of the triangle. Treatment-free remission. Remember I said we don't actually talk about cures per se. We talk about remission. And we can even have in this day and age what we call treatment-free remission, which is where a person has stopped taking the medication when it's been undetectable for a long time and it stays undetectable. We don't send you away at that time, though. We continue to watch and do the PCRs on a regular basis just in case it eventually at some point were to grow back. So generally, you have to have had a deep molecular remission, so that undetectable state for at least 2 years before we try taking away the medications. And we actually usually then start doing the PCR testing. We might have been doing it every 3 to 6 months. We start doing it monthly for the first few 6 to 12 months, because if you're in that narrow part of the triangle where it's still there and you take away the drug, it's going to start creeping up, and that usually happens in the first year. So in order to try stopping, you have to have only ever had chronic phase, be an adult, have been on treatment for at least 3 years, and undetectable for 2 years. Reasons to try and stop: to reduce the side effect of the drugs. Sometimes it's about pregnancy, and sometimes it's just about the inconvenience of taking a daily medication and putting these drugs in our bodies. So we ask patients if they want to stop when they reach the state where they possibly could. We're not trying to say you must. But some people really want to, and some people are nervous, and we do whatever's best for whatever patient. We need, as I mentioned, in about 40 to 60% of people, it will come back. And that's because we weren't far enough down in that narrow triangle there. And as far as we know, worldwide for the last 10 years, if people stop and we start the drug again, they go back into remission, back to their undetectable state. So it's okay to try if you meet the criteria, but it's a 50-50 kind of shot. Yeah, I already talked about this. Clinical trials. Some of you may be eligible for clinical trials. Um, the purpose of clinical trials is sometimes to help, the individual patient possibly receive what we think is a better drug, and then also overall help the greater advancement of knowledge about conditions. And clinical trials are not only for people with most advanced disease, sometimes they are for people where nothing else is working, but sometimes they're for maybe a new drug is better to use at the beginning. And sometimes clinical trials are just about improving the quality of life, not necessarily the drug working better. There's lots of possible clinical trials, and um, if you're interested in that sort of thing, you should always ask your physician. So we, absolutely ask that you let us know if you're having any side effects. Ask questions, ask for your blood tests. If you're not in a province where you have access to things online, your doctors and nurses will always be happy to print them off for you. And we're happy to discuss the results and draw you some pictures and try and answer all your questions. Um, there's just, there are long-term effects possibly of being on these drugs. The longer you're on drugs, the more you might have side effects. And late effects are even things that sometimes can show up after you come off drugs. There's not a lot of late effects with the CML drugs, but there can be long-term things. Things we worry about are chemo brain fog, problems like I've mentioned in the heart, lung, livers, kidney, and then psychologic effects, whether those are the drugs themselves or the diagnosis leading to these, to depression and PTSD from having a cancer diagnosis. So, healthy lifestyle habits are important, just like they are for anybody. Regular physical activity, maintaining a healthy weight, eating well, limiting alcohol and tobacco, wearing your sunscreen. Once you have one cancer, you are at more increased risk of a second cancer. So sunscreen, tobacco, those things, avoiding them. And obviously managing your stress and getting all your vaccinations that you're eligible for. So being as healthy as you can in general is going to make you more tolerant of the drugs and the disease. And I think we're going to see if there's any questions.
Thank you, Dr. Savoie, for sharing all your expertise and insight with us. So it is time for a Q&A period. If you haven't done so, be sure to use the Q&A box in your Zoom webinar panel to type your questions. As we mentioned earlier, due to the large number of participants and limited time, we may not get to all the questions. And please note, Dr. Savoie cannot answer specific questions about a person's health, history, or status. So I'm just going to provide you with the first question. Does dasatinib affect the makeup or composition of a patient's sweat?
Not that I'm aware of. I'm sensing that's a personal question that somebody's experiencing something. Um, I have not heard that before or seen that mentioned in any of the literature.
Okay. Do TKIs have side effects for hair loss?
Doesn't come up a lot in the literature, I think probably because people weren't asking about it. It's not very common, but I have certainly had patients who've talked about hair thinning, both on their head and one particular woman I know was very distressed about her eyebrows seem to be thinning.
Mm,
So I certainly have seen it, but it's not out there in the formal literature.
okay. Is there ever a point after years of taking a TKI where particular side effects would no longer occur? For example, if you're taking dasatinib, is there a number of years beyond which pleural effusion would not be expected to occur?
No, and it's actually the opposite. So a lot of those things that I mentioned that all the TKIs have, the nausea, the vomiting, diarrhea, rashes, etc., those often are at the beginning when your body's getting used to the drug. Some of the other side effects like liver, kidneys, heart, and the fluid around the lungs can happen actually the longer you've been on the drug, the more exposure you've had to the drug. And so no, unfortunately, the side effects do not go away long term, those ones.
Okay, so can people build up a tolerance to TKIs with a prolonged use?
So possibly, and one of the mechanisms of that is possibly this mutant in the mutant, right? But there are other people where we see a TKI was working and then it stops working. We do the test for the mutant in the mutant and we don't find that. So there's clearly other mechanisms at play where some people, a certain TKI may stop working for them. And so we're lucky we have the other drugs that we can look at. But there is possibly some sort of tolerance like that that happens, yes.
Okay. So what can be done about protein in urine on dasatinib?
Nothing really specific can be done about it except possibly switching drugs if the protein is significant enough to cause kidney problems. So normally we would sort of talk with a kidney a s- kidney specialist, a nephrologist about all that.
Okay. So what does the latest research show for treatment-free options down the road?
I'm not sure exactly what we're saying there, but there's mostly right now it's the newer drugs, like say is asciminib better. There's some clinical trials looking at combining asciminib with one of the standard TKIs because they work slightly differently. There's studies that have looked at TKI with the interferons. So probably sort of combinations. Also, as our test improves, we used to be able to measure to 3 logs. Now we can measure to 4 and 4.5 and 4.7. Um, so knowing that the CML is most likely truly gone, the more sensitive the test is. That's sort of where things are at right now.
Okay. So how do we ensure conditions are optimal in the stomach for TKI absorption?
So, well, we do need acid to absorb most of the TKIs. And so the use of things like proton pump inhibitors, your Losec, your Pantaloc, those are not ideal to be taken with TKIs. So sometimes we'll try and suggest people use a less potent acid suppressing drug like Zantac or ranitidine or even just Tums. So we try and see what patients can get away with, the least amount of acid suppression. Um, But of course, having heartburn isn't pleasant either, and we understand that. So sometimes we do have to sort of juggle the timing of the drugs, and the pharmacists are really helpful at that in deciding, if taking them 12 hours apart or taking it 2 hours before you take the acid suppressing. Or there are some sort of strategies that a pharmacist can help with.
So what are the risks of various CML treatments causing heart damage and or pulmonary hypertension?
So pulmonary hypertension is seen primarily with dasatinib. Other heart troubles seem most prevalent with ponatinib or nilotinib. With which is part of the reason why we reserve ponatinib for the more advanced or serious cases. Nilotinib, it's unclear if it causes the problems directly or if it causes the problems to the heart and the blood vessels because it increases the risk, worsens the diabetes or the sugar control, which we know people with diabetic are at increased risk of heart troubles. So what we need to make sure that our patients, and we try and work with the family doctors to make sure that things like cholesterol, blood pressure, diabetes are as optimal as possible, exercise, all those things, so that if we need to use a drug that has some risks to those organs, that we're in a better shape, as good a shape as we can be. But if people have those troubles when they come to us, we try and avoid those medications and use the others.
Okay, thank you. So last question. What is the best way to improve my red blood count?
It depends why it's low. So, you need to make sure that you have enough iron and B12 and folate, and so your doctor can check those things. Um, if your kidneys are not working, sometimes your red blood cell count will be not as good. So then you need to work on your kidney health. Sometimes the red blood cell count is always going to be a little bit lower than it should be on these drugs. And if it's just a little bit low, that's okay. Also, if people have other chronic conditions and are on a lot of medications and are ill with a lot of things, our marrow doesn't always work 100%, so it doesn't necessarily make as many red cells as it should do.
Hey, thank you so much, Dr. Savoie. Your expertise is very valuable for us. We're going to turn back to the slides. So if you could just pop up the next slides, we can sign off for today.
There's your next slide.
Okay, so before we sign off today, I would like to remind everyone of our upcoming conference this week, ALL, November 7th at 3 p.m. Eastern, and how to actively participate in your cancer care, 1 p.m. Eastern Time. Next slide, please. We would like to thank AbbVie, Astellas, AstraZeneca, Bristol Myers Squibb, Jazz Pharmaceuticals, Johnson & Johnson, and Novartis for their support in making these conferences possible. Next slide, please. Please remember that we are here to help you. You can reach us by email by visiting the website, bloodcancers.ca, or by calling us toll-free. Please note a short survey will be sent to all participants after this presentation. Please take a moment to respond as it helps us plan for future events. And last slide, please. So just thank you for being with us today and take good care of yourself.